MOYAMOYA disease. MOYAMOYA disease is an idiopathic, non-inflammatory, non-atherosclerotic progressive vasculo-occlusive disease involving the terminal supraclinoid internal carotid arteries and circle of Willis, which leads to characteristic intracranial vascular changes. Numerous entities have been described which mimic the appearance, in which case the term MOYAMOYA syndrome is used, which then can be further broadly divided into atherosclerotic causes and vascular T or inflammatory causes. MOYAMOYA is a disease of children and young people, with a bimodal age distribution, occur in early childhood, peak till 4 years of age 2/3, and middle age, 30 to 40 years of age 1/3. Clinical presentation. Presentation is to some degree age-dependent. In children, hemispheric ischemic strokes are most pronounced, whereas in adults hemorrhage from the abnormal vessels is more common. Watershed infarcts are also very commonly identified. Pathology. The underlying pathological and genetic basis for MOYAMOYA disease is not well understood. Fibrocellular proliferation and thickening of the intima is the main process responsible for vascular stenosis and occlusion. The associated neovascularization may be a compensatory mechanism or part of the disease process itself. Radiographic features. General. MOYAMOYA disease affects the bilateral distal ear and circle of Willis. Up to 18% of patients with MOYAMOYA may present with unilateral angiography documented disease. Small abnormal net-like vessels proliferate, giving the characteristic puff of smoke appearance on direct angiography. CTA and MRA are not always able to demonstrate this appearance on account of lower flow and spatial resolution. Although classically described affecting the ear, over 50% of patients also have involvement of the posterior cerebral arteries. Generalized cerebral atrophy is a common finding. Watershed infarcts are also commonly seen. Cerebral hemorrhage is more likely to occur in adult patients. Chronic patients present with collateral circulation formation. MRI. In addition to demonstrating the arterial stenosis best seen on MRA or enlarged perforators best seen on T2 weighted images, vessel wall imaging can also be helpful, particularly in distinguishing MOYAMOYA disease from MOYAMOYA syndrome from atherosclerotic or vasculitic or inflammatory causes. Vessel wall imaging in MOYAMOYA disease typically demonstrates concentric luminal narrowing, none or only minimal enhancement, and homogeneous T2 signal. Treatment is bypassing the occlusive segments is the aim of most surgical therapy, and this can be accomplished by direct or indirect revascularization. Differential diagnosis are cranial radiotherapy, atherosclerosis, phacomatosis, neurofibromatosis type 1, tuberous sclerosis, infection, tuberculous meningitis, bacterial leptomeningitis, post-varicella vasculitis, CNS vasculitides, connective tissue disorders, systemic lupus erythematosus, hematological disorders, sickle cell disease, antiphospholipid syndrome and aplastic anemia.